So good afternoon, everyone. Today we are discussing about B7H3 CAR-T in solid tumors. We will first start with the intracranial one and a brief of what exactly is B7H3, and then we will proceed further. So B7H3, also known as CD276, is a member of the B7 family of immune checkpoint proteins, and it is highly expressed in cancer cells and activated tumor infiltrating immune cells. It helps the cells to evade the surveillance of cytotoxic T cells and natural killer cells and further helps the cancer to proliferate. Emerging evidence have shown that B7H3 is involved in tumor proliferation, METs, treatment resistance, resulting in poor patient outcome, and hence B7H3 emerged as a promising therapeutic target for anti-cancer therapy. The temporal and spatial overexpression of B7H3 in a variety of cancers, but low expression is in normal tissues, indicated the pathological significance of this immune regulatory protein. Its degree of expression and localization in the blood, CSF, in exosomes and nucleus has been associated with clinicopath features of cancer and hence patient survival. Crispin et al. Reported that enhanced tumor expression of B7H3 correlates with adverse clinical and pathologic features of cleared cell type RCC and independently predicts disease progression and cancer-specific death. In a meta-analysis of 24 observational studies consisting of 4,141 patients, an elevated baseline B7H3 did significantly correlate with poor OS and recurrence-free survival across a wide range of tumor types. The study concludes that elevated B7H3 is significantly associated with poor survival in cancer patients. So this is like the mechanism. B7H3, it influences the immune response and cancer progression through both immunological and non-immunological pathways. Although the receptor has not been identified, it is assumed that the activated CD4 and CD8 T cells express a receptor that can be recognized by B7H3 expressed on APC cells or tumor cells. Expression of B7H3 favored an immunosuppressive microenvironment by promoting the production of interleukin-10, TGF-beta, and inhibiting the activity of CD4 positive T cells, CD8 positive T cells, gamma delta T cells, CAR T cells, V delta 2 T cells, Th17 cells, CD3, NK, macrophages, neutrophil, dendritic, and also inhibiting interferon gamma, IL-2, perforin, and granzyme. The role of B7H3 in proliferation of cancer cells has been documented in cervical, gastric, and many other cancer types, whereas in a few studies, significant proliferative effect was not observed. In addition to regulating the immune environment, B7H3 has been reported to activate signaling pathways like PI3K, ERK, STAT3 in cancer cells, which may lead to accelerated cell proliferation and tumor growth. B7H3 increases the reactive oxygen species production through an unknown mechanism in the cytosol of tumor cells and promotes the stabilization of hypoxia-inducible factor 1 alpha to increase the glycolysis. Inconsistent with this finding, in oral SCC cells, B7H3 enhanced glycolysis through the upregulation of HIF1 alpha and its downstream targets including GLUT1 through PI3K, AKT, mTOR pathway. A decreased expression has also been noted to reduce the glycolytic capacity in breast cancer cells also. So these studies clearly indicate that it is involved in cancer metabolic flux and supports its pathogenesis. So this was how it is helping the cancer cells to proliferate. Now how it is playing a role in treatment resistance also. Enhanced expression of B7H3 in tumors has been linked with treatment resistance, metastatic potential, and poor patient prognosis. Liu et al. Showed the effect of B7H3 on Pacli-induced cytotoxicity. In their study, breast cancer cell lines were more sensitive to paclitaxel when B7H3 was silenced, which may be associated with the prevention of activation of JAK2 STAT3 pathway. In ovarian cells, Zhou et al. Reported that overexpression of B7H3 induced the activation of PI3K AKT signaling pathway and upregulated the BCL2 in protein level, which led to further chemoresistance. So this is how it is playing the role in treatment resistance. And now coming to 4 approaches of anti-B7H3. So first is through the monoclonal antibody. block. Second is through the CAR-T, which we are concentrating upon. Third is through ADC and ADCC, that is antibody-directed cell cytotoxicity. And fourth is through a BiTE, that is bispecific antibody. So these are the four mechanisms. Now coming to the various ongoing clinical trials of B7H3, and as we can see, they are involving multiple subsites, right from multiple myeloma to neuroblastoma, ovarian, SCLC, various solid tumors, GBM, and also midline glioma. So I will first concentrate upon this study, which was presented in ASCO 2025 this year, and it is a phase 1 study of B7H3 intracranially in recurrent GBM. This was done by Stanford School, and we are discussing it further. So current landscape, we know that in recurrent GBM, the median overall survival is just 7 to 12 months. So this was a phase 1 trial which was done to determine the feasibility, safety, and the RP2D of monthly intratumoral and intraventricular B7H3 CAR-T. The B7H3, the results were that we can manufacture it, it is feasible, and 25 million cells intracranially is safe with on-target reversible tumor inflammatory associated neuropathy. So this is the B7H3 background, like how it functions in recurrent GBM with the mechanism of immune escape, tumor invasiveness, and the protocol which was followed was that it was delivered intracranially within 7 days of resection monthly for total of 6 doses. And there was no lymphodepleting chemotherapy given before this B7H3 intracranial CAR-T. And the key eligibility criteria were high-grade IDH wild-type glioma at first recurrence after initial treatment. Standard of care, which was the repeat resection, was planned. Prior bevacizumab taken patients were allowed if bevacizumab dose was used as a steroid-sparing agent for radiation necrosis or pseudoprogression. And even less than 4 mg per day of dexamethasone, patients who have taken this were also eligible for the treatment. So other criteria were like GBM, including but not limited to glioblastoma, even gliosarcoma, oligodendroglial features, PNET features, everyone was included in the study. And although the number of patients were quite less, only 9 patients were there. So further studies are needed as it was a phase 1 trial. Patients must also have evidence of tumor regression or progression by MRI using the RANO criteria. And first recurrence of progressive disease after a standard first line, even those patients were included in the study. Now, the definition of resectable disease was taken as like resection is being considered a part of standard care for the patient, and it is thought that it is feasible that a majority of contrast enhancing tumor with a mass signal effect can be resected. Patients between age of 18 to 75 years were included and a KPS score of more than 60. And we have already discussed about the Dexona dose. So these are the adequate organ function parameters, which are more or less same in all the CAR-T studies which we are seeing these days. Even the ejection fraction is same. Now about the prior therapy. So at least 6 weeks following completion of frontline radiation therapy, 3 weeks post chemotherapy or 5 half-lives, whichever is shorter, must have elapsed since any prior systemic therapy. At least 4 weeks from bevacizumab treatment for radiation necrosis dose or pseudoprogression, prior cytotoxic chemo, radiation, or other anti-cancer therapies, including investigational agents, should be discontinued at least 4 weeks prior. Toxicities due to prior therapy must be stable and recovered to less than grade 1. The exclusion criteria was use of bevacizumab in any other dose other than for radiation necrosis, prior exposure to any other CAR-T therapy, known sensitivity or allergy to any agents or reagents, receiving anticoagulation therapy, and prior malignancy except previously diagnosed and definitively treated more than 3 years prior to the trial or whose prognosis is deemed good enough to not warrant surveillance. Clinical evidence of significant increased ICP or uncontrolled seizures, these patients were also excluded from this trial. So, presence of any sort of infection that is uncontrolled or requiring any form of IV treatment were also excluded. And even the patients who had any triple H positive were also excluded from this study. Primary immunodeficiency or history of autoimmune disease resulting in end organ injury or requiring systemic immunosuppression within the last 2 years were also not taken in the study. Now, patients who have poorly controlled hypertension, cardiovascular, diabetes, COPD, pulmonary fibrosis, or any other immunocompromised condition, they were excluded from the study, along with patients who have history of previous bone marrow transplantation were also excluded. So this was how the procedure was done. We all know this is the Umaya reservoir, and the catheters are placed either intraventricular or intra in the post-op cavity, tumoral cavity, and through that the CAR-T is given intra cerebrally, and such 6 doses were done. So these are the results. Like we can see the green diamonds are the 10 million cells and the pink ones are the 25 million cells. And these are the patients who were on treatment and follow up, like days since B7H3 CAR-T were taken. Now coming to the treatment associated inflammatory neurotoxicity. So the most common like adverse event which was which happened in all 100% patients was headache, followed by hyponatremia, nausea, somnolence, intracerebral edema, and then around 50% patients of the experienced aphasia, hemiparesis, vomiting, confusion, and tremor. So these were the non-hemat side effects, and the hemat side effects were like lymphocyte count was decreased in 80% of the patients, anemia was present, and WBC were decreased in around 50% of the patients, with decrease in the platelet count in 40% of the patients. So the median overall survival, which we saw through this, was 13.5 months, and 12-month overall survival at 1 year was in 50% of the patients. And the median follow-up of all censored patients was around 9.9 months. So the key takeaways from this study were like only 10 subjects received B7H3 CAR-T in this, and the primary endpoint, which was whether the feasibility of manufacturing is there or not. So yes, it was 100% manufacturing success rate, and median time from apheresis to first dose in this study was around 14 days. Now, the grade 2 hypertension was the one dose limiting toxicity which they saw in 20% of the patients, and at dose level 2 which they took into consideration was 25 million cells. There were 82% TIAN rates, and 13% patients out of all these had grade 3 TIAN. The median overall survival was 13.5 months, and extensive 5 additional subjects had been rolled for RP2D dose, that is 25 million cells. So this was one study. Now coming to the second study, which is also a pediatric midline glioma study. We'll discuss that as intracerebroventricular B7H3 for DIPG. This is Brainchild 3 study. So before going into that, I will just give a brief of what was Brainchild 1. Brainchild 1 was for HER2 specific CAR-T, 2 was for EGFR specific CAR-T, and this 3 is for B7H3 CAR-T to children with recurrent or refractory CNS tumors and DIPG. So this is a Nature study which was published in this January 2025. And it was a single center dose escalation, again a phase 1 clinical trial of repetitive intracerebroventricular dosing of B7H3 CAR-T for children with recurrent or refractory CNS tumors and DIPG. So they have taken arm C into account. Arm C, as we are saying, that out of all the cranial tumors, they have just taken DIPG into account. That was the arm C of this study. The primary objective were to assess the feasibility and tolerability, which were both met, and the secondary objectives included the assessment of CAR-T cell distribution and survival. The eligibility criteria in this was up till the age of 26, and DIPG confirmation both through radiologically and histopath confirmation of high-grade glioma or H3K27 altered DMG at any time point following the completion of standard radiation. There should be presence of a CNS catheter and KPS performance of more than 60. DEXA dose in this protocol which they have taken is less than 2.5 mg per meter square per day, and defined washout from previous therapies and protocol defined lab evidence of adequate organ function. So these were the patient characteristics which were present in this study. The median age of the patient was 6 years, and around 14 patients were females in this study out of the 23 patients. Um, 50 more than 50% of the patients had good performance score. The median month from diagnosis to enrollment was 6 months, and the disease history at enrollment, like previous progression, was present in around 52% of the patients, that is 12 patients. And disease history at first dose of B7H3 CAR T, like previous progression, treated on previous progression, was again the same number. And radiation, all patients have received, like all 100% patients, 23 patients have received previous radiotherapy. So 23 patients were enrolled and 21 were treated with repeated doses of ICV B7H3 using intra-patient dose escalation regimes without previous lymphodepletion. Concurrent tumor-directed therapy, including re-irradiation, was not allowed while on protocol therapy. Total 253 ICV doses and were given, and established the highest planned dose regime, which was at DR4, which escalated up to 10 into 10 to the power 7 cells per dose as the maximally tolerated dose regime. So it delivered ICV B7H3 CAR T cells without previous lymphodepletion every 14 days over 8 weeks during the dose limiting toxicity observation, that is course 1 and course 2. As the optimal number of doses is unknown, patients who met the criteria for subsequent infusions beyond course 2 and for whom additional cryopreserved CAR T cells were available were eligible to continue receiving CAR T cells beyond the dose limiting toxicity period, with doses every 2 to 4 weeks. So in the previous study, we saw that it was a monthly infusion every like total 6 doses, whereas the duration in this, we will see further that it will vary from 2 to 4 weeks. Patients were treated on 4 escalating dose regimes. In DR1, 3 evaluable patients received 1 into 10 to the power 7 cells per dose. DR2, 3 and 4 used intra-patient dose escalation. In DR2, 6 evaluable patients received 2.5 into 10 to the power 7 cells. DR3, 3 patients received just the double, 5 into 10 to the power 7 cells. And DR4 was again double of that, that is 10 into 10 to the power 7 cells per dose. DR2 expanded to 6 patients owing to a dose-limiting toxicity of intratumoral hemorrhage, and DR4 expanded to 6 patients for a planned statistical confirmation of the maximally tolerated dose regimen. For patients who began treatment before any progression, that is, there were 9 patients out of the 23, the median time from diagnosis to initial CAR T cell infusion was 6.6 months. For patients who began treatment after progression, that is 12 patients, the median time from initial diagnosis to initial CAR T cell infusion was 10.3 months. For all patients receiving at least one CAR T cell infusion, the median interval between enrollment and initial CAR T cell dose was 1.4 months. The 18 patients evaluable for dose limiting toxicity received 253 total doses and remained on protocol therapy for a median of 5 months. So this is the consort diagram of what we were discussing till now. This was the dose of first week in DR1. And this is just the double. We can see course 2, week 1 dose in the DR2, that is 2.5. Here 5 into 10 to the power cells, and DR4 is ultimately 10 into 10 to the power 7 cells. Tumor biopsy was not requirement for enrollment because B7H3 is expressed on most of the DIPG tumors. This limits the safety analysis but restricts the ability to correlate efficacy with the degree of B7H3 expression. Like what exactly at what percentage the response will come. Because of this limiting factor, we cannot decide that on the basis of this study. To assess other metrics of CAR T cell activity, CSF cytokine levels, and confirm signals of intracranial inflammation following CAR T cells, although the small patient number preclude correlation to survival. It is clear that cytokine related to CAR T cell trafficking, such as CXCL10, are elevated following the infusion, although it is impossible to specify that this is directly from the CAR T cell engagement with the target antigen and that the concentration gradient peaks within the tumor. There was a study which also correlated that the decrease in the CXCL10 concentrations is associated with the time of the tumor progression. So these were the adverse events and during the DLT observation period, right from the neurological effects, which were like grade 1 and 2 in around 70% of the patients. Like we can see headache was present, then ataxia was present in 14%. Majority patients had headache as the main symptom, followed by paresthesias. These were the neurological symptoms. Then around 10% patients had photophobia and 5% had diplopia. GI symptoms of nausea, vomiting were present in majority of the patients. Like vomiting was there in around 70% and nausea close to 60%. And tumor hemorrhage did not happen. Only it happened in one patient, that too grade 4 tumor hemorrhage. Hence, it was the dose limiting toxicity. Now coming to the constitutional symptoms, fatigue was present in around 62% of the patients. In the respiratory symptoms, dyspnea was quite less, but hiccups were there in around 30% patients, and remaining musculoskeletal symptoms were also present. Now, hematotoxicities were very less, only grade 1, and that too in one patient only it happened. So these are the curves of the Kaplan-Meier curves, timing since the CAR T infusion in months, if we see. So this is like the first curve which we see. This was for all treated patients, and it was for the patients who had like the red one, the graph which we see, it was patients who already had progression before the first CAR T infusion. And obviously the better graph, that is the blue one, this is present in those patients who did not had any progression before the first CAR T was given. So the median survival of 19.8 months was there for all treated patients. It is superior to the historical median survival of 11.2 months and the 9.4 month survival after the initial CAR T cell infusion for patients enrolled after progression. It is superior to less than 3 months, which is the historical data which we have. For all treated patients, that is 21 patients, the median survival from the initial CAR T cell infusion was around 10.7 months, and the median survival from the diagnosis was 19.8 months, with 3 patients alive, still alive at 44 months, 45 months, and 52 months from the diagnosis, which is we all know, a good number for DIPG. Ultimately, this completed first in-human trial, which shows that repetitive ICV dosing of B7H3 CAR T cells in the pediatric and young adults with DIPG is tolerable, including multi-year repeated dosing, and may have clinical efficacy that warrants further investigation in a phase 2 trial. So these are the 2 studies which I have covered for the intracranial. I think I will close it today for this.